Hello, this is Dr. Grant Cooper at Princeton Spine and Joint Center. This video is going to tell you everything you need to know about lower back pain. And we're going to do it all in just under 17 minutes. So if you or someone you love has back pain, this is going to be the video for you. All right, we have a lot to cover and under 17 minutes to do it in, so let's get started. Right off the bat, there's a very important distinction that we need to make between acute and chronic lower back pain. Acute back pain is back pain that lasts for less than 6 weeks. Subacute and chronic lower back pain lasts for longer than that. Now, why is this distinction so important that we make it right away? It's because we understand what causes subacute and particularly chronic lower back pain really well. There are in fact 3 main causes, and we'll discuss those in a minute. But first, by contrast, acute lower back pain is a completely different animal. By its nature, it usually resolves itself by itself in a few days or at most weeks. And so for one, there's just a lot less research about it. That doesn't make it unimportant. Acute lower back pain can be awful. I've had it, you might have had it. It's extremely common, and it has many causes. The most common of these causes is thought to be a bad muscle spasm that can happen because of overuse or simply a bad twist or movement. Specifically, the quadratus lumborum, which is a deep muscle in the back, is very prone to spasm, as is the gluteus medius. Now, acute lower back pain tends to respond really well to gentle, targeted stretches. In our video on acute lower back pain exercise fixes, we go through 3 excellent stretches for very quick relief. Let's turn our attention for now to the more nuanced and arguably interesting topic of chronic lower back pain. As we mentioned, there are 3 main causes of chronic lower back pain. Specifically, the most common cause, accounting for 4 in 10 cases, that's 40%, is the intervertebral disc. Now, you've probably heard of herniated discs before, and you know that about 3 in 10 people have herniated discs without having any symptoms at all. But to be clear, herniated discs, even when they are symptomatic, don't really cause back pain in and of themselves anyway. Rather, herniated discs, when symptomatic, can irritate a nerve and cause leg pain or sciatica, but that's a different conversation. No, when discs cause lower back pain, it's actually because of a tear on the inside of the disc called an annular tear. Now, an annular tear can occur in a herniated disc, but it can also occur in a disc that on the outside looks completely morphologically and structurally normal. Basically, the disc is like a jelly donut. There's an outer crust, which in the disc is called the annulus fibrosus, and an inner jelly, which in the disc is called the nucleus pulposus. So it kind of looks like this. The nucleus pulposus gives the disc its cushioning effect, but it gets that in part through a series of inflammatory proteins inside the pulposus that, if they get next to a nerve, will cause inflammation, which in turn is what causes pain. Now, fortunately, there are no nerves inside of the disc. And there's a rule. If there are no nerves, there's no pain. However, in the outer third of the annulus of the disc, there are nerve fibers, and that basically looks like so. And what happens in an annular tear, and here's the annulus, is that you get a tear that looks like a pie. And the jelly in the middle of the disc seeps out. It irritates the nerve fibers in the annulus. And then anything that increases the pressure on the disc will tend to exacerbate the back pain. It turns out that the worst position for a disc is in sitting and bending forward. The second worst position is standing and stoop forward at 30 degrees. So for example, think of the position someone's in when they're opening a window or shoveling snow or brushing their teeth. Now, the next worst position is sitting. So the worst positions for people with discogenic lower back pain, or back pain that's coming from the disc, is sitting and bending forward, standing while leaning forward, and sitting particularly with poor lumbar support. When these positions increase a person's pain, it suggests that the disc is the source of their pain. By contrast, standing and leaning backwards tends to take the pressure off of the disc and therefore feel good for people with discogenic back pain, or again, back pain from the disc. Now, this is the basis for McKenzie physical therapy, which is basically extension bias therapy. For those of you who may have heard of McKenzie techniques, which are very common physical therapy techniques. Now, the second most common cause of chronic lower back pain are the facet joints. The facet joints are the small joints in the back of the spine. This is the lower back. Here are the facet joints in the back. Facets are normal mobile synovial joints like a hip or a finger or a shoulder. And just like any of those joints, facet joints can become arthritic and they can become painful. And in 3 in 10 cases of chronic lower back pain, slightly more common in older people, less common in younger people, facet joints are the source of chronic back pain. Facet joints are in the back of the spine, so anything that puts the spine into an extension movement, like standing, and particularly standing and leaning backwards, tends to make the facet joints hurt worse, whereas sitting and bending forward makes the pain better. So of course this is exactly opposite of the disc. More on facets and discs in a moment, but first let's discuss the third most common cause of chronic back pain, which are the sacroiliac joints. The sacroiliac joints are big, tough, fibrous joints where the spine meets the pelvis. They're in the buttocks and they can present in a variety of ways, but are much less predictable in how they present in general than as opposed to facets or discs in terms of their clinical presentation. The most common predictor of sacroiliac joints being the source of someone's pain is actually when a patient can take 2 fingers and they point exactly to the source of pain. They point exactly to their sacroiliac joint, and basically they say, there, that's the pain. And they're pointing right at the SI joint, as if to say, yeah, it's my SI joint, doc. So this is the front of the spine, the back, and here's the sacrum. There's a bone here called the ilium, and that's the sacroiliac joints. And they cause about 10 to 20% of chronic lower back pain. Now, the remaining 10 to 20% of chronic back pain cases can often be diagnosed with an MRI, such as in the case of an acute fracture or metastasis from a cancer, which are rare, but do happen and so have to be thought of. And then there is some chronic tendinitis, particularly, again, the gluteus medius tends to be a problem here. And then, of course, there are probably going to be about 10% of cases where we may have a suspicion of what might be causing the pain, but we just can't say medically exactly what the source is. We aren't able to make a definitive diagnosis. And so we have to go ahead and, as we say, treat empirically, which is to say we rule out the bad stuff, like tumors, and then we treat the clinical symptoms as best as we can. This can be very effective, but of course we would always rather have a diagnosis first, because then life is a lot easier to know what to do and to know what to expect when we do it. So, how do you go about definitively diagnosing a person's source of chronic lower back pain? We already mentioned that pain that worsens with bending forward and sitting is more likely to be from the disc, and pain that's worse with standing and leaning backwards is more likely to be from the facet joint, whereas sacroiliac joint pain is more variable in terms of how it presents, but it's typically located directly over the sacroiliac joint itself, although again, it doesn't have to be. While these are all good rules of thumb, they are only rules of thumb. Many people just don't follow the rules. If only they did in this case. We have imaging, of course, but imaging is actually very limited for diagnosing back pain. Of our imaging choices, CAT scan, X-ray, ultrasound, MRI, etc., MRI is generally the best tool to evaluate the spine. But if the disc has an annular tear, for example, MRI will only find it 30% of the time. And the real kicker, excuse me, is that even if there is an annular tear on the MRI, many people are going to have one and have no symptoms. This is because the body has put scar tissue down over the tear, so there's no longer any inflammation there. But the MRI will still pick up the old tear, so you see it. Similarly, people often have arthritis in their facet joints. Indeed, by the time a person is 65, almost everyone does have arthritis in their facet joints, though most don't have symptoms from that arthritis, and maybe they never will. And even if the MRI does look normal, as perhaps in a younger person it might, that person can have pain from micro tears inside the facet joints that are completely missed on MRI. And MRI is unfortunately not diagnostic of sacroiliac joint or SI joint pain either. Now, why is it that arthritis in the facet joints or annular tears in the disc that we see on MRI sometimes cause pain and sometimes don't? The answer, as we just touched on, is in whether or not there's inflammation present. If arthritis or a tear in a disc leads to inflammation, there will be pain. If there's no inflammation, there won't be pain. And it's that simple. In a tear in the disc, if the disc has scarred down and the inflammation is resolved, then there won't be any pain. And similarly, if the facet joints or the sacroiliac joint is arthritic, but there's no inflammatory response to the arthritis, there won't be any pain. If there's inflammation in any of these places, it'll hurt. Now, what is inflammation? Well, inflammation is a protein response, but the best way to think of it is that it's like a fire. And there are two ways of putting out a fire. One way is if you move away all the fodder and all the wood, and you let the fire die down by itself. In this case, in the spine, this can mean surgery, but much more commonly, it means doing targeted exercises. It means getting the biomechanics of the spine such that you take the pressure off of the injured part so that it has a chance to scar down and heal itself. We go through those exercises in our video on exercises for chronic back pain. In short, though, they involve strengthening the core, integrating the core with the pelvis, and also stretching some key muscles that help unload the spine. The spine, you see, is like a mast on a ship. And you know how a mast has all those ropes and all that rigging that attaches to it on a ship? Well, what happens if the ropes aren't there? What happens if the rigging's not there? The mast falls down. It can't support its own weight. So those ropes are there to unload the mast. Now, in the same way, if you took your spine out of your body and you placed it on the ground, and you put an axial load on it by pushing down, you could get about 35 pounds of pressure before things started to break. As big or as little as you may be, you weigh more than 35 pounds. We all do. Our muscles attach to our spines, and we rely on those muscles to help unload the spine so that it doesn't fail. And what happens is if our muscles are tight or weak or imbalanced, then they can't protect the spine properly, and the discs and the joints have more pressure going through them as a result. But on the flip side, when our muscles are working well and properly balanced, they unload the spine better and take the pressure off the damaged part. That's why the right targeted exercises for your back can work so well. Back to our other analogy, sometimes you move away the sticks, but the fire just keeps on burning. And then you have to take some water and put the fire out with the hose. In the case of the spine, that means using medications to take away the inflammation. Those medications can be oral, such as non-steroidal anti-inflammatory medications, which can be over-the-counter like Advil or Relieve, or they can be prescription strength. Or they can also be supplements like turmeric or bromelain or tart cherries, for example. Oral medications have a built-in limitation in that only about 2% of the medication that one takes by mouth actually reaches the inflammation in the spine. That's obviously a big limitation. For this reason, oral medications can be good for pain, but they have a limited role in taking away the actual inflammation around the spine, even if you take oral steroids. Sometimes doctors will therefore use X-ray guidance to inject anti-inflammatory medication, which are generally steroids, into and around the source of inflammation. In the case of the disc, the best way to inject medication around the disc would be an epidural steroid injection. In the olden days, we used to inject into the disc itself, an intradiscal injection, but for a host of reasons, this just didn't work. So the best we can do is try to inject around the disc instead, and this also has real limitations. In the case of the facet or the sacroiliac joint, this would be an injection into that joint. One advantage to the injection into the joint is that it can also serve as the best way to diagnose the cause of pain. The way this works is that when you inject the steroid, you also inject an anesthetic like lidocaine. If the lidocaine temporarily relieves the pain by numbing it, then this confirms that you're in the right spot. If you're in the wrong spot, there just won't be any temporary relief. The pain will be the same after the injection as before. Now, when it works, the anesthetic will wear off in a few hours, and the steroid takes anywhere from several hours to a couple of weeks to be metabolized and become active. Usually it takes a few days to a week to see most of the effect of the steroid. And then the activity of the steroid continues to crescendo up to about 2 weeks. Now, the steroid is designed to take away the inflammation. If injections are used, or if oral medication is used, then the anti-inflammatory effect, when it works, because it doesn't always work, should be thought of more as offering a window of opportunity, during which the inflammation is resolved or mostly resolved, and so the pain is much improved. Note that as opposed to the anesthetic, using an anti-inflammatory when it works doesn't mask the pain. It's removing the inflammation, which is what's directly causing the pain. But it's also not fixing the mechanical part of the problem that led to the inflammatory response in the first place. So ideally, once the inflammation is improved, it should be used as a window of opportunity during which the patient can work on his or her exercises to stretch and strengthen the right muscles to unload the spine so that as the medication wears off, which it always will, the inflammation doesn't return. As an important final note, in the case of facet joints and sacroiliac joints, if they're confirmed to be the source of pain by the anesthetic, by the lidocaine that's injected, but nothing else is helping the pain, doctors can perform another type of needle procedure called a radiofrequency rhizotomy or ablation. This procedure actually burns the sensory nerve that innervates the joint so the patient doesn't feel the pain anymore. It's a safe procedure, and in the right patient done correctly, it works very well. But unfortunately, the nerve does tend to grow back in about 6 to 18 months, at which point the pain tends to return, and also at which point the procedure can be repeated if needed. For this reason, even after a rhizotomy procedure, ideally the patient will still do their exercises to help change the mechanics so that ideally the pain never returns, even as the nerve regenerates. In the disc, unfortunately, there's no ablation procedure possible, and so in cases that just aren't responding to more conservative measures, fusion surgery remains the gold standard for discogenic back pain. That's your 17-minute back pain tutorial. I believe we finished in time. I hope you found it useful, and if you have enjoyed it and you've learned something, then please remember to like this video, subscribe to the channel, and tell a friend who might also enjoy it, because that's the way that we can spread good health information and achieve good health outcomes together. As always, if you have questions that you'd like me to answer in a future video, or if you have any comments, you can reach me at drcooper@princetonsjc.com, or of course leave a comment in the comments section. Thank you very much.